Hi, I'm Andrea Traynor. I am an OB anesthesiologist at Stanford, and I'm here to talk to you about drug shortages. So, in short, I have a shortage of disclosures. I have nothing to disclose. I'm just an ordinary OB anesthesiologist working every day and getting emails about drug shortages. How many people in this room have experienced drug shortages in the last month? I think it's everybody. Okay, so it's pertinent to all of us. These kinds of comments are coming up on a daily basis. We have no fentanyl and only 2 vials of epi for an entire ASC. This was posted by an anonymous Facebook poster in one of the anesthesiologist groups that I'm in. And I think this is an extreme example, but this is something that, people are coming up with on a routine basis. So that's why I'm here speaking. So let's look at this. The University of Utah has been keeping track of this for a while, and this isn't a new problem. So as you can see by this slide, where on one side you've got the number of drugs, and then on the bottom you've got the year, starting back in 2001. This problem kind of peaked in 2011. We don't have numbers for 2018. To me, it feels like it's more, but I don't have numbers yet for 2018, but it peaked in 2011, and I vividly remember that time, and I will talk about some of the things that we did during that time to mitigate the problem then. These are the types of drugs that are in short supply. As you can see at the bottom, they're not actually recording anesthetic drugs, but we do have things like electrolytes and CNS drugs, cardiovascular drugs. The electrolytes are in short supply right now, things like bicarbonate, things that we tend to go for. So why is this happening? I mean, it just seems to defy logic. You show up at work, you're ready to work, you've done all your CME, you've read your black box warnings, you've done everything that you're supposed to do, and then you show up at work and you're told that there isn't enough of a drug that you need to use, or there's not a needle that you need to do a required procedure. And the question is why? So this is information from the University of Utah again, and if you can see on the right side in the red, there's 30% of it is manufacturing. So from what I can tell, and I've tried to read and I've tried to really figure this out, like why? What is going on? So manufacturing is part of it, where there's a decreased number of suppliers and decreased number of places that drugs are getting manufactured. So that makes fewer production lines, and so sometimes the drugs that we use a lot are not on the production line, probably in lieu of some more profitable drugs, but I haven't been able to really find any documented evidence of that, but it would just stand to reason that drugs that have a higher profit margin may be on the production line a little bit faster than drugs like bicarbonate that nobody makes any money off of. You can see in the light green supply and demand. So that's an issue, kind of old-fashioned economics, but it's only a small piece of this, so the old-fashioned economics don't really apply here. Raw materials, so or an issue with maybe the preservative that's in the medication that we use. But it's glaringly obvious that on the other side here, this big, like well over half of the pie, and 53% is unknown. So I'm not really sure what to do with that. I think that means that there's a lot of different reasons, and it's really hard to really pinpoint exactly why. For our opioids, the DEA actually has decreased the number of opioids in production by about 20% in 2017 in an effort to work on this opioid crisis. And they've also decreased it even further in 2018. So that is part of the problem as well. So I think that this big, giant half of the pie that says unknown is actually really multifactorial, and there's different reasons for different drugs in different places. So this beautiful place, anybody know where this is? Or have a guess? This is Puerto Rico. And as we know, Hurricane Maria hit Puerto Rico on September 20th, 2017, and as of February 20th, 2018, 900,000 people were still without power. Why does this, other than from a humanitarian perspective, why does this affect us? This affects us because Baxter International, among other companies, produce 40 to 50% of our IV fluid bags in the US in Puerto Rico. Other drugs are made in Puerto Rico. So now we don't have IV fluid bags, say for instance for our pediatric ORs, so they're using 1 liter bags for like 4 kilogram kids and just being really careful with the buretrols and making sure that they don't leave the trainees alone and making sure that the buretrols are really carefully monitored. A lot of drugs on the wards are being given by IV push now, so if you think about it, a lot of the nurses will use a 100 cc or 250 cc bag of saline and then give the drug and then put it on an infusion pump, but now they have to give it by IV push, and that's a difference in practice, and it has a huge impact on nurse staffing and a huge potential for drug errors. So what drugs are in short supply? My job here, I got 30 minutes to speak about this. I could speak for an hour on the supply and demand and the whys. I could speak for an hour on the different options and the ethics and a lot of different things. So I'm going to overview a lot of things, but emphasize what we need to do day in and day out, because that's the best I can do with the limited amount of time that I have. So what drugs are in short supply? I mean, I'm told at my institution it's things like fentanyl, bupivacaine, hydromorphone, morphine, the IV fluid bags. But I wanted to know, because I've worked in different places, and I had the experience in 2011 working in one hospital where we had no preservative-free morphine, and literally walking across the street to a different hospital, and there was no shortage. So to me, that tells me that there are different drugs that are short in different places. So I did what we do these days, and I went on Facebook, and I just asked in some of the forums that I've been able to be a part of, and I said, what drugs are in short supply, extra special, gold star bonus points, if it's OB related, but I'll take anything. And here's basically the responses. I had 53 comments. And you can see here on this list is essentially everything we use. So you've got IV fluids, you've got all opioids, all anesthetic gases, phenylephrine, hospital won't make PCAs anymore. I got comments like, not just a shortage, but replacement with odd-looking ampules. Our new 2% lidocaine in plastic ampules looks exactly like normal saline. I heard that the hospital across the street is totally out of 2% lidocaine, so dosing add-on C-sections with 0.5% bupivacaine, or removing the epidural and doing a spinal, which, as we know, carries the risk of a high spinal. So then begs the question, what do patients want? What are we supposed to do with this? And actually, there was a group at the Mayo Clinic that looked at this and published it in 2015. They had 256 respondents. They were querying patients that were having elective cholecystectomies. They had a 27% response rate, and they asked the question, do you want to be told by the anesthesia doctor about a neostigmine drug shortage if there are slight differences in the side effects of the drug substitute combinations? And the overwhelming majority said yes, they want to know. The desire for information increased with an increased difference in the substituted drug side effects. 80% said they wanted to delay surgery if there were major differences, but actually 33% said they might delay surgery even if there were small differences. And there was no difference with gender, age, or educational level. And there were a couple of accompanying editorial articles that came out with this paper, and talking about the ethics of this. And that is not my topic for discussion today, but it's definitely something to think about. What are the effects on patients? That's what patients are going to want to know. I read on the news, hey, my friend's on this Facebook page, and they said this, and tell me what's going to happen to me. C-sections are the most common surgery that we perform in the United States. So we've got patients coming in, they're going to have heard of this. So what do we tell them? Does it cause harm? This is really difficult to prove because, we're trying to come up with adequate shortages, and we've got people in this room that really want to learn and want to come up with alternate things so that there aren't patients that are harmed. This is a study that came out in JAMA looking at 26 United States hospitals and patients that were admitted to ICU for septic shock between 2008 and 2013, and their N was 27,000 patients. So the norepinephrine use went down from 77 to 55% during this time, and phenylephrine use was the most common vasopressor substituted, and it went up from 36 to 54%. They did find that during the shortage time period that the patients admitted for septic shock during those times had a higher in-hospital mortality, and it was statistically significant. It was about 39% versus 35%. Now, it's important when I'm showing this to not say this caused a problem, because this is an association. Maybe it just means that phenylephrine isn't the best substitute, but it's definitely something to think about, and it's definitely out there. So I was tasked with talking about solutions. So what are the solutions? What can you take back to work on Monday morning? Well, some days it feels like I'm in an episode of Iron Chef, where I get a secret ingredient and I have to come up with an anesthetic plan based on a secret ingredient, just like the chefs on Iron Chef had to do, where they would get a secret ingredient of mushrooms and then have to come up with this amazing dish in a short period of time at a professional quality with the secret ingredient. And then some days I feel like I'm on an episode of MacGyver, like the day when I showed up and they said, hey, guess what, we're out of those, those Gertie Marx needles that you guys use, those ones with the brown caps, we're out of those. And I said, okay, there has to be some. I mean, I can't just do an entire day on labor and delivery with no way to do a CSE. So, some days you feel like you're MacGyver having to piece together, with ordinary objects how to actually get your way out of a problem. So let's start looking at local anesthetics. So this organization that puts on this meeting, and my fearless leader and the president of the organization, Dr. Brendan Carvalho, came out with a statement just recently in the last week, maybe 2 weeks ago, by SOAP, looking at this problem of the shortage of local anesthetics. And here's what they said. Bupivacaine solutions with epinephrine are expected to come out in maybe March 2018, so hopefully we're good with those, because it's March 8th, or actually it's March 9th, isn't it? So hopefully we're good there. Isobaric bupivacaine solutions, sometime mid-March, okay, so we probably are going to be getting those. Ropivacaine at the end of March or in May, according to the origin of the ropivacaine supplier and where you are. So, you may have it at one hospital and walk across the street and not have it, but ropivacaine in a lot of places is not in short supply. But what about our gold standard? What about hyperbaric bupivacaine? How many people in this room use hyperbaric bupivacaine for all of their spinals, or most of their spinals? Okay, pretty much everybody. Who doesn't? Like on a routine basis, use hyperbaric bupivacaine. Okay, one person. So this is the person ahead of the game. Let's ask him all of our questions about how to not use hyperbaric bupivacaine. So what's happening with that? The next shipment will be announced in April 2018. That's when they're going to tell us when we might see it. And they're thinking sometime in September 2018. So that gives us a good 6 months without our hyperbaric bupivacaine that we have come to use as a routine gold standard. So here we are back on Iron Chef, and our secret ingredient it's what we've chosen at our institution as a substitute, and it's widely available, and it's 0.5% isobaric bupivacaine. So if these Iron Chefs can figure out how to substitute their ingredients and get a trip to the White House, we figured that these Iron Chefs, my group at Stanford, can figure it out too. And that's what we're trying to do, is switch over to using 0.5% isobaric bupivacaine every day. So there's a Cochrane database review looking at isobaric versus hyperbaric bupivacaine, about 10 studies. They saw no difference in the conversion to general anesthesia and no difference in the need for supplemental analgesia. They used ephedrine use as a marker for hypotension in this study, and they saw no difference. And the main difference was that hyperbaric bupivacaine had a shorter onset to T4 block height, and the mean difference is about a minute. And I was telling my residents this, and they said, yeah, that's a really, really long minute. So it's probably a lot longer than a minute. It's probably 3 to 5 minutes. Just be patient. So what's the dose? So our group, my colleagues at Stanford, Dr. Carvalho and my colleagues at Stanford, in 2005 published a dose-finding study with 0.5% isobaric bupivacaine. They used a CSE technique, and they said success was a T6 level to pinprick within 10 minutes of drug administration, and failure was not obtaining T6 within 10 minutes and dosing the epidural catheter. And this is their dose response curve, and they found that the ED95 was about 13 milligrams for 0.5% isobaric bupivacaine. So the SOAP statement is based in part on this study, and recommends that if you're going to be dosing 0.5% isobaric bupivacaine, that you use 2.5 to 2.6 mLs if you're using intrathecal opioid, assuming you have it, which is about 12 to 13 milligrams. And if you're not using intrathecal opioids, it's about 3 mLs, which is about 15 milligrams. Next, I'm going to focus on post-cesarean pain control, because this is one of those situations where I can't reteach all of pharmacology in 30 minutes, so I have to choose what I'm going to focus on. So next, I'm going to talk about post-cesarean pain control. And the gold standard there is preservative-free morphine. How many people have that in short supply? Okay, whether it's intrathecal or epidural. In 2011, that was a really big deal. We were completely out for a while. And during that time, we used intrathecal hydromorphone, which actually hydromorphone in my hospital is almost impossible to obtain. But I put this up here because maybe it might be relevant for your hospital. This is what we used in 2011 when I was at University of Colorado. We changed over to hydromorphone when we didn't have intrathecal morphine. So the relative potency of hydromorphone IV is about 5 to 1. And there's a study looking at the ED90 for cesarean delivery using the up-down sequential method. And on the left side, you can see there's hydromorphone. And on the right side, there's morphine. And over on this side, you can see there's the numeric pain rating post-operatively and the dose. So when you look at these doses of hydromorphone next to morphine, the pain scale is pretty similar. And interestingly enough, even at 24 hours, my concern was that it wouldn't last long enough, that it wouldn't be effective as long as morphine, but the study does not bear that out. And they showed that the ED90 for morphine was 150 mics, and for hydromorphone it was 75 mics, giving a relative potency for intrathecal use of 2 to 1, and they didn't see a difference in side effects of pruritus or nausea using hydromorphone versus morphine. Okay, so if you don't have hydromorphone and you don't have intrathecal morphine, another option would be to do a TAP block. So if you don't know how to do TAP blocks, then I highly recommend that you learn them. We have them taught at workshops for SOAP, or you can go to other workshops or learn online or learn from a colleague. So essentially what you're doing is you're depositing local anesthetic between the internal oblique and the transverse abdominis muscle. And down here at the bottom, you can see there's the local anesthetic spread on and obviously this is not one of our pregnant patients, but it was a good view of where you put the ultrasound probe. So there's numerous studies showing that TAP blocks are not equivalent to intrathecal morphine. And I'm not going to get into them too much, but essentially this is one study here showing that there was higher postoperative pain scores, but actually lower side effects in the TAP group. And then this is another study where they looked at 4 different groups, and they found that the TAP group, they had intrathecal morphine and then a sham TAP block versus intrathecal morphine and a TAP block with bupivacaine had no difference in morphine consumption and pain scores, and higher antiemetic use in the patients that had intrathecal morphine. And again, a big review showing basically the same thing with the conclusion that there was no benefit of TAP versus intrathecal morphine, which is why we don't routinely do TAP blocks at our institution when we have intrathecal morphine. But what if you don't have intrathecal morphine? Then TAP blocks become a pretty nice thing in your armamentarium. So if you don't have intrathecal morphine, or if you're just deciding that you'd like to do TAP blocks, the doses for that would be about 50 to 75 milligrams of bupivacaine per side. And if you're using ropivacaine, keep in mind ropivacaine has a potency about 40% that of bupivacaine, which becomes important if you're using it for labor analgesia. And so the dose is a little bit higher, 75 to 150 milligrams per side. You can also add clonidine to your blocks and consider always multimodal analgesia with acetaminophen and NSAIDs. And you might even find that, as this study did, they looked at an ARIS program, and they found that the patients that had the TAP block versus intrathecal morphine actually were getting up and mobilizing a little bit sooner and walking a little sooner and had earlier return of GI transit. So I'm going to talk briefly about clonidine. My colleague, Dr. Flood, talked about it a little bit ahead of time, and I have the privilege of working with her, so I've had the privilege of being able to get much better at using clonidine in various situations. We've occasionally used them for labor epidurals, and this in particular is talking about intrathecal clonidine. Again, if you don't have intrathecal morphine. So this is a study where, this is a Cochrane database review where they excluded intrathecal morphine, and they found that the 24-hour post-operative morphine consumption was decreased with the addition of clonidine, and the time to first analgesic request was increased. They did find an increase in intraoperative hypotension, as Dr. Flood alluded to with the black box warning, talking about bradycardia and hypotension, and an increased use of vasopressors. So just, I guess, anticipate that, because if you need to, addition of clonidine may be an option to reduce postoperative morphine consumption if opioids are scarce. So I'm going to go over one thing that kind of seems a little bit out there, seemed really out there when my friend, who I'm going to allude to in a minute, told me about this, but I think it's an interesting thought. What about epidural meperidine? That's a unique thing, but actually there is a hospital in St. Louis with 7,000 to 8,000 deliveries a year and a 40% cesarean delivery rate that for about 30 years used epidural meperidine postoperatively as part of their pain service and pain regimen. And the only reason that it got discontinued, because everybody liked it so much, was because the hospital took the meperidine away and took it off the formulary. But now it's back. So my friend Christy Morgan presented this at SOAP as an abstract. This is a private hospital called St. John's in St. Louis, but they had a ton of experience with it, and she thought she'd share it with us in 2011. I think it's just as pertinent now. So anyhow, what they do, or did, is they have a continuous infusion for 36 to 48 hours post-operatively at about 8 to 12 mLs per hour. So they'll do a CSE, or even at times they were doing just a straight epidural for C-section, or a CSE. You leave the epidural catheter in, and then you can run epidural meperidine. If there was inadequate analgesia, it was managed with 10 to 20 milligram boluses, and then they removed the epidural catheter on post-op day 2. They did a retrospective chart review. This is not a randomized controlled trial. It doesn't go head-to-head with intrathecal morphine, but they reported this, and they found that their VAS scores at rest were in the 1s, 1 to 2, and with activity they were 2 to 3. So definitely good pain control. The patients were happy. And they did have to treat side effects of itching and nausea and vomiting. But when they reported it, it was the treatment for pruritus was 17% versus 29 to 38% for morphine that's reported in the literature. Again, this was not a head-to-head randomized controlled trial. This is just me digging up an old SOAP abstract as a potential option if you're out of everything else, because at our hospital, meperidine is one of the few things that we have. The treatment for nausea and vomiting was 8% versus 9 to 22% for morphine, and their conclusion in their abstract was that epidural meperidine was well tolerated and provided excellent post-cesarean analgesia. So it's just something you can pull out of your sleeve, or at least say, hey, I've at least heard of this. So in short, I do not have a magic wand. I cannot stand up here and tell you these magical things that are gonna make everything better, that are gonna, I don't have a magical solution. I've hit the books just like all the rest of us, where, essentially we find out about something and we have to go and review. One of the biggest pieces of advice that I can give you is to make friends with your pharmacist. I called our pharmacist and I was like, what am I going to talk about? How am I going to do this? What do I say? I don't know what to say. And when I spoke with her, it was actually the beginning of a really nice relationship. The other members of my group have had a long-standing relationship with her, but she guided me through some things, and she said, we can work with you. You just have to tell us. Because they have to look at the entire hospital, so they're looking at everything, and we're looking at just our day in and day out functioning. So we have to tell them what we need. They can do things like aliquot essential drugs for us. If they just know that they're essential and that they're in short supply, they can aliquot for us. They can mix or produce drugs that maybe we shouldn't be, that we normally use as single use, but if they're in short supply, maybe they can help us. She told me to figure out your pie in the sky drugs, the ones that you absolutely cannot live without, 4 to 6 of them, and just let them know. Say, labor and delivery cannot live without these drugs, and these are what we need. And that they would try to make an effort to stockpile them for us so that we had a supply of them. Stock your pantry so that you can be the next Iron Chef. So the take-home messages are: understand drug shortages, understand the pharmacology of the drugs you use frequently so you can assess alternatives. Coming up with solutions for this talk was almost like trying to figure out how do I reteach all of pharmacology in anesthesia school at once in 20 minutes. So ultimately this has to come from you or us or our colleagues. You need to voice your concerns, and you need to make friends with your pharmacist and make sure that you're working together for the best care. They're frustrated by these things too. They want the patients to be well cared for. They don't understand any more than we do in terms of why these things are happening, and everybody wants the same thing. A thought just to kind of think about is an information repository for things like this. If I hadn't happened to know somebody that had used epidural meperidine for a long time, I wouldn't have had any idea about it. Or potentially an app. We are in Silicon Valley, right? What if there was an app for, you got your secret ingredient, right? I have isobaric bupivacaine today. What am I going to do? Or today I have mepivacaine, or, take your pick. And maybe there would be an app that would show us, hey, these are the relative potencies and these are the things to watch out for. Somebody smart in the audience can think of that. So thank you very much for having me. I'd like to thank our pharmacist and the Stanford OB group, my friend Christy, for sharing her epidural morphine or meperidine slides. The Facebook group was awesome. They had a lot of great information about what's going on out there. And last but not least, I'm going to put in a little plug for OB anesthesia as a specialty. First of all, it's a really, really fun way to spend your career being an OB anesthesiologist, fellowship trained. And if you're interested in a fellowship, we love talking to people about OB anesthesia fellowship at Stanford. So I guess that's it.